Hello, my name is Dr. Zara and I'm a perinatal psychiatrist working in Melbourne in Australia. I'm really excited to talk to you today on World Maternal Mental Health Day and share my passion with you about working with women in the perinatal period and working together with their families before, during, and post-pregnancy. I want to talk a little bit about high prevalence disorders such as depression and anxiety that are very common in the perinatal period also. 1 in 10 women will have antenatal depression, and up to 1 in 7 women experience postnatal depression up to 12 months postpartum. 1 in 5 women will experience antenatal or postnatal anxiety, so those disorders are very, very common as well. Other disorders such as eating disorders and lower prevalence disorders like schizophrenia and bipolar affective disorder can also be exacerbated in the perinatal period. So it's really important to have careful screening in place in the antenatal period. Of note, 1 in 1,000 women will also experience the rare but serious psychiatric emergency that is postpartum psychosis. So having a knowledge of these conditions is really important when caring for women in the perinatal period. I think it's very important to think about supporting women during this time through education and empowering them with decision making. I try where possible to involve a support person, ideally a partner, and think about antenatal screening. We often use the Edinburgh Postnatal Depression Scale in pregnancy also, and weigh up some social risk factors that may also contribute. Once we have an idea that mental health services need to be involved, being involved in the antenatal period allows for continuity of care from the perinatal period starting in pregnancy and then moving on to postpartum, which really allows you to establish that therapeutic relationship and trust with women and their families, and really to optimize care coordination between mental health services, GPs, maternity teams, midwives, obstetricians, and later on maternal child health nurses and pediatricians, just to name a few of the health care professionals involved. I always like to think about how in the perinatal period you've got the mother in front of you, but you also have the baby and a broader family unit to think about. And we know investing in maternal mental health can have such a positive flow-on effect in terms of that family development. So when I see someone and I'm trying to conceptualize what's going on in front of me, I draw sometimes on the 4 Ps as a basic starting point. So predisposing factors, which are things that make the woman vulnerable to the development of mental illness. Perpetuating factors, which are things that contribute to the ongoing mental illness and maintaining that. And precipitating factors, which we can think about as the triggers that often prompt referral to mental health services. And it's so important to remember the protective factors, the strengths that the woman and her family bring to you, the protective factors that help mitigate those risks, and really things that you can draw on when you treatment. I think it's always important to think about a woman's own attachment background and any history of trauma, because it can often emerge again in the perinatal period. And it's important to be mindful of that and have a sensitive approach to it. I also think that thinking about cultural factors is imperative. We know that there are so many different customs around the perinatal period and raising children that we need to be able to respect so that we don't alienate people. So in terms of treatment, across the range of mental illness, psychoeducation is really important. Determining the most appropriate setting, which where possible will be in the community with a woman and her baby, and only really where there's an acute risk will you think about more intensive support, such as an inpatient setting where ideally there is the baby present also. In terms of treatment, thinking about that biopsychosocial model. So really thinking about psychological support, biological aspects, thinking organic screen, excluding thyroid disease and other organic illnesses that may be contributing towards a woman's mental state and presentation. And then also thinking when it comes to medications, making a very tailored, individualized risk-benefit ratio discussion with a woman and her partner, where you can collaboratively talk about the risks and benefits, provide written information, and help them make an informed decision. Social aspects include involving the partner, other family members, and making sure the basics such as housing, finances, are all stable and ready to welcome a baby into that environment. Lifestyle factors seem quite straightforward but are incredibly important. So, thinking about healthy eating, going for walks, getting some exercise, minimizing caffeine intake, avoiding substance abuse, and really importantly, thinking about self care, given that it's that concept of putting your own safety mask on first. I like to also make sure that women have a plan around if their mental state declines further and how to seek emergency support, whether that's in an emergency department or crisis numbers. Special considerations in pregnancy include a mental health birth plan, so really liaising with the maternity ward and letting them know that a woman is vulnerable to the development of mental illness and how best to support her or escalate her care if needed. And postpartum, thinking about differentiating baby blues that are relatively common in the first 2 weeks postpartum from more persistent, pervasive low mood as seen in postnatal depression. It's important to think about adjustment to parenting mothercraft such as feeding, sleeping, and settling, as well as the parent-infant relationship. And there are therapies that can also focus on this where there seems to be a lack of emotional connectedness or delight between mother and infant. Optimizing supports that are both practical and emotional supports, and sometimes where possible having group supports, other mums with babies that they can really connect with during that time. I always like to think about cultural factors again when it comes to access, and I know that in Australia, a number of cultures have confinement periods where women may not leave the house for 1 month postpartum. So really thinking about things like telehealth screening to enable them to still access support and be screened so they don't slip through the cracks. It takes a village to raise a child, and we also need to be there for women to support them in their roles as mothers, and which are often very rewarding roles but very challenging. And so I'm really happy to have had the opportunity today to share some of my passion with you about maternal mental health. And I'd encourage you to reach out to me if you have any questions or would like any further information. PANDA, which is the Perinatal, Antenatal and Depression Australia website, have great resources that you can share with women and their families. And I'm more than happy to talk about more resources if anyone is interested. So thank you again for letting me speak to you today about this important topic. All the best, and I hope that you really take the time to celebrate this important day and women's mental health.